All right, well, I'm delighted to hear the hubbub in the room and to know that there is so much worthwhile conversation going on. And certainly what I noticed at lunchtime was very intense conversation between many, many people who are obviously enjoying catching up with friends new and old. Now, this afternoon, we have the opportunity to spend some time thinking both back in terms of what has happened in the past, but also thinking very much forward to what are the policies and the processes and the practices that are going to lead us forward in terms of rural health research. And Isaac Newton said that if we've seen further than here, it's because we've been standing on the shoulder of giants. I want to tell you as a midlife career researcher and clinician that I have certainly had the opportunity to stand on the shoulders of some of the giants that we see both on the podium here and we will see in the next session. And I want to say on behalf of all of us in rural health to say a huge thank you for the walk and the journey that they have taken themselves on, but also that they have taken many of us on. So without further ado, I'm going to hand over to Lesley, and I will be a tiger with timekeeping because I commit to you that you will be out of here at 3:15 for afternoon tea, and that will be quite a hard gig. And that is because, as I said, we have such inspiring people with us. Now, Lesley Barclay is probably well known to many of you, but she was the first clinical chair in midwifery and family health in Australia, and she is one of the few foreign women who was designated a Samoan chief, recognising 20 years of work with colleagues in that country. And she has supervised or been involved in over 45 PhD and honours students in rural Australia. And to that we say a big thank you. David Lyle has lived in Broken Hill for 23 years, moved there in 1995, and is a full-time or part-time cyclist and prefers full cream milk to skim milk in his coffee, sensible man. Lucie Walters is the second woman to hold the office of President of the Australian College of Rural and Remote Medicine and once went snorkelling with a small 8-metre white whale shark off Ningaloo Reef in WA. Ross Bailie studied medicine at the University of Cape Town in South Africa, and in 2014 Ross did volunteer work as an evaluation advisor in Malawi, which I think would have been a very interesting and eye-opening thing. And I'm delighted to have Dennis McDermott with us, and Paul Wally has already alluded to Dennis's expertise and advice and wisdom. Dennis has family connections with the Gadigal land and the Gamilaroi country, but also speaks fluent French and German. So we are in the arms of experts. So it says. And I'd like to welcome Lesley to convene the panel. Thank you, Lesley.
Okay, thanks, Jenny. Some of us have been around for quite a long time. Lucie's a bit younger than most of us, but I won't introduce you because you've had a lovely introduction, but we are difficult to shut up. And that is in part, I would say, because we had a lot of experience. It could be just that we like to talk, but this experience hopefully is valuable. And what we're going to do is work from some questions that hopefully will be responded to from the panel, not by 5 minutes, each person having a separate question. But I'm going to ask David to start because David's probably been longer around this area and started some of the original work. So David, please, what do you think the key influences, issues, people, policies, programs have shaped where we are now with rural and remote health research?
Thanks, Lesley. Yes, I'll be speaking very much from a lived experience, but I'd like to talk about two particular elements to that process. One was in the 1980s. The 1980s was a time when the health sector and state health departments in particular recognised the need for a systematic approach to the development of health policy and services in addition to clinical practice. So there was this need for an evidence-based approach to policy and practice. It was also associated with a rise of public health training, which was, for those at the time would know about the Kerr-White report. And that created a workforce with skills in health service and systems research, evaluation and development, which was driven by the need for an affordable, cost-effective and accountable health system. So that was the precursor for a system that was starting to think about evidence and research. The second was something that recent times I've just been reflecting on, which in the 1990s, which in the lead up to the 1990s, there was the decline in the social and economic conditions in rural and remote Australia, and there was a recognition of health workforce shortages. That garnered political responses, which culminated in the first National Rural Health Strategy that had two broad components: a focus on the development of local and regional development of health services to overcome gaps and shortages, to improve access, but also a response to workforce shortages. And one of the key strategies was the coalition government's 1996 policy around establishing university departments of rural health and subsequently rural clinical schools. Now, UDRHs had not only a workforce, a training objective, they also had a population health service and development objective. And many of the original directors actually had public health backgrounds. So what that decision had made is to create a infrastructure embedded in health services, not in universities, that actually started to focus on developing that evidence base. Now, this is just one part of that development. Clearly, regional universities were also developing. But as a way of demonstrating, and that platform has sustained and developed over the last 20 years, just to give you some idea, research done at the end of the 1990s, if I remember correctly, reported about 136 research-based articles over a 10-year period in the Australian Journal of Rural Health and other Australian journals. Now, in the UDRH and Rural Clinical School Network alone, there are over 1,300 academics, clinical academics and full-time academics working. In a 10-year period that would equate to the 10-year period of the 1990s, there are over 3,500 publications that have come out of that network alone. So I think that what that demonstrates is these two key shifts in policy and in investment have generated a sustainable and a substantial platform from which research is developed and is flourishing.
Thanks, that's a really good start to our discussion. Lucie, would you like to take that a little bit further? And what do you think the enablers or blockers are to rural health research?
Yeah, look, I'm just interested in the fact that one of the disadvantages that rural people have in Australia is that we're a minority. But one of the huge advantages are that we're a vocal minority. And in fact, the Rural Clinical School and UDRH programs have actually demonstrated this in the research and in the education sector, where previously that was existed only in the population sector. So one of the things that I found really, inspiring for myself, and which I think has been really important in research in rural medicine, is that we need the evidence base, because without that we can't stand shoulder to shoulder with the other health professionals that have an academic background from the city. But we also need the rich stories that actually are often the things that inspire and motivate. And so rural people tend to be good orators, and we've got the best of them as our Rural Health Commissioner now. And certainly my experience is that the very beginning of the evidence of how we could bring people out to a rural area and educate them was, I read in Paul Worley's very first papers, but it was the oration from him and the stories from the students that were in rural people that made that come alive for me. And so I think that we need to think about the momentum of the rural research that has occurred through the UDRHs and the rural clinical schools. We need to think about the political changes that have occurred within Australia at very key positions. So the political agenda that enabled us to become, or to argue for UDRHs and rural clinical schools, was actually about the fact that the Commonwealth government, Liberal government, needed to engage with the National Party and engage rural constituents again in their cause, and that enabled a huge transition and focus on health for rural Australia. So for me, we need to think about in policy and research, it's the evidence and the stories.
Can I just come in with a point there? One of the things that really interested me, having just done some work with Gordon Gregory, and I don't think there'd be anyone in the room who doesn't know Gordon, he said, as we worked on the origins of the National Rural Health Alliance, that for him it was evidence that actually helped him to be so politically powerful, and the National Rural Health Alliance to be so politically powerful. And that alliance has been very powerful. So as an institution, where do you see the National Rural Health Alliance fitting? Do you see it still, you know, when you're talking about universities and you're talking about our motivation and our capacity to tell stories, do you think that that organisation has a role?
I think that the National Rural Health Alliance is key to being able to unify the very many diverse voices in rural Australia, and it's that amazingly complex tension between the fact that each of us and each community has its own unique story, as each health professional group has its own unique story, but the commonalities in those stories bring strength. And so I think the National Rural Health Alliance continues to be a very important group in terms of helping to set the policy agenda going forward.
And it also brings the shared story. You know, we've got our own stories and we've got our country stories or our professional stories, but it brings a shared story, and that story is very powerful, I think, with government.
Sorry. Yes, and the other thing that I would really like to think about is that one of the wonderful things about rural health is that we have such small communities and communities of practice that it positions qualitative research as being a really fundamentally important way of seeing, not to separate or in any way detract from the quantitative research that's really set the scene for rural health in Australia over the last few years. But we have been able to push the agenda of what research means in health much better than has happened in the tertiary institutions, where they have the numbers to perhaps focus solely on quantitative research.
I might ask if that microphone can come to Dennis, because this was one of the discussions that Dennis and I had that he might offer about one of the challenges that we still have.
A particular challenge or challenges more generally?
Well, challenges more generally, but then do come to the particular ones that you can speak about.
Yes, certainly. I think from an Indigenous point of view, one of the key challenges has been to take that desire we've seen in the last 20 years to spread out into the social determinants of health in our research paradigms. But actually, how do we actualise that? How do we make that sing? You know, I'm thinking also particularly not just the social determinants of health generally, but if you like, the social determinants of Indigenous health are another way of describing the situation. And that starts to bring in such things as culture, recognising culture as a determinant of health. It starts to bring in such things as racism. And for the first time, many of you will know that the National Aboriginal and Torres Strait Islander Health Plan from 2013 was the very first one to mention the R word. And that is now recognised as a determinant. We have to recognise it as a determinant. You know, it's not just about people feeling bad. It's about the physiological effects of racism, huge physiological effects. If we don't factor it in, then we can't get anywhere with our patients or clients or communities. And as I think Paul Worley pointed out earlier today, if we don't factor in organisational racism, then our efforts are also for naught. So there's quite a few challenges. I could go on with some more, but let's see what other people have to say as well.
Why don't we focus now on methodologies that enable us to deal with some of the challenges that remain?
All right, I'll just say two, I think, of particular importance. And one is the workforce, because we find in teaching, and Paul alluded to some of the work we've been doing at Flinders around, if you like, the pedagogy of Indigenous health and cultural safety. And we find particularly that there is a challenge here, which is that when we work with either students doing their first degrees in health, various health disciplines, or practicing professionals doing professional development, the same challenge arises, which is that it's inherently challenging to look at oneself and one's nation and the history of the nation and the stats and the narratives that we're talking about. It's really challenging. There's resistance. It's not monolithic resistance. From one end of the spectrum, people get it straight away and want to be truth tellers and champions. At the other end of the spectrum, there are 5 or 10% of students and practicing professionals who couldn't give a toss, who are overtly hostile, sometimes overtly racist in class or on back channels on social media. And in between are a whole bunch of people who get it to some degree, who are either moved by what they hear, and some are flummoxed by it, completely thrown. And now I'm realising this resistance is not just about, personal choice. It's about what I'm a psychologist, not a medico, we psychologists call cognitive dissonance. We're asking people to take in fresh information that actually argues and jibes with everything they've ever heard all their life, and certainly here on Murdoch Media. And so that's a big challenge. It throws people, it pulls the rug out from under people's feet. So our pedagogy and our curriculum must take into account these challenges that people face with the dissonance. And I'll mention one very brief thing we'll be doing now, Lesley, which is saying, look, we need to learn from Aboriginal ways of doing things. And in the Balgo area, Western Desert in the north of Western Australia, there's a term some of you may have heard called Kanyanyimpa. And Kanyanyimpa is a way of describing the holding that goes on for young Aboriginal men going through into adulthood. Because it's a challenge for anyone transitioning making that kind of change. And so the young men are held emotionally and spiritually through that challenging journey. Well, our work now is saying, why don't we do this with students? Why don't we say, this is a journey we want you to come on, it's going to be difficult, it's going to be fraught, we'll make it safe for you, we'll hold you through this journey. So one challenge is workforce, and I guess, I forgot my other challenge, no, I know.
Indigenous methodology,
Thank you,
please.
Connie or Lesley. She won't let me off the hook. We're also trying to find ways of what Professor Sir Mason Jury calls the interface between Western ways of research and Indigenous ways. And that's a challenging area. The beauty is, using a Yolngu term, when saltwater and freshwater meet, this is not my term, this is a Yolngu way of looking at things, something extra is created. And that's the foam of the saltwater meeting the freshwater. And that foam is the new knowledge. So if we can find ways of doing that, and one of the ways we can do that is to tap into, we talked before about places that are unique, places that are distinct around Australia, certainly with Aboriginal nations. But there are commonalities. And there are commonalities in such things as listening, deep listening. And there's a word for it in every Aboriginal language I've come across, which is about deep listening. It's a bit like mindfulness, listening with your whole body. If we can teach our health professionals to do it, if we can do it as researchers, then we're starting to pick up on the subtle stuff. Quickly, another one is Uncle Lewis Yulaburka O'Brien, Ghana elder, I've learned from since I've been in the last 9 years in Adelaide. And he talks about a thing called seeing doublies, or seeing two ways. And he's not talking nonsense. He's trying to say, if you look at a mountain, what's on the other side of the mountain? If you read a text, what's beneath the lines? If you see a presentation, what's behind the presentation? It's sometimes holding two contradictory things in your mind or in your purview at the same time. If we can do that as researchers, we're starting to get to the nub of things. I should shut up.
No, but that's really helpful, because one of the things that Aboriginal researchers and others who are working with Aboriginal people doing research are starting to develop techniques that we haven't had in the past, that certainly aren't 50 years old or the randomised control trial. They're particular techniques that enable us to see this complexity of meaning, to see the doublies. It's a lovely way of describing it. I want to come to Ross now, because one of the things that Ross's research has done, and I became aware of this when I went to the Northern Territory and became aware of his work quite a long time ago, 10, 15 years ago, was his research, what I have tried to do with my research, was actually part of a process of changing the system, of translation, of improving the system. Ross, would you like to give us some insights about how you as a researcher work to translate, disseminate, but far more than that, to engage the system improvement?
Is this on? Yeah. Thanks, Lesley. And I think what quite a bit of what I'll have to say is synergies with what Dennis was saying. And part of the major achievements, or the extent to which we have made progress, is down to the increasing realisation of the potential for research to drive service and system improvement. And I think they're possibly, I'll just single out 3 key things that have helped with that, and that is the emergence of or recognition of the value of participatory, system-oriented and action-oriented research, and the need and importance of this is probably brought to the surface most acutely in the field of Indigenous health research. So from a participatory research perspective, just to unpack those 3 things a little bit, I think I'm saying similar things to what Dennis is saying, but in different words, is really the recognition of partnerships and genuine partnerships. And there's good research literature on what makes for good partnerships and the principles that you need to follow in order to work effectively in partnerships. And there's remarkable similarities or parallels between that and what is in the values and ethics statement for Indigenous health research. And so just to single out a couple of those, the one is around spirit and integrity, which is described as holding all of the other values together. So I think the way that we approach as researchers, the way that we approach those partnerships with the spirit and integrity in which we approach those is critical, and it needs to be with a shared sense of purpose. So, I mean, that's a critical requirement for effective partnerships, is really a shared understanding of what do we hope to achieve through this research. Reflecting on sort of systems-oriented approaches, researchers, I think, I hope, are increasingly seeing themselves as part of the health system and research organisations as part of the health system. And so we're moving away from this sort of expectation that researchers are kind of stand on the outside and need to be independent and looking in. We are part of the health system, and to be effective, we need to be part of the health system. So I think, working effectively in partnerships with a systems approach and respecting the roles, the different roles and the different strengths that different individuals and different organisations or groups bring to the research process is we're seeing more of that happening, or that happening more effectively.
And it's actually getting funded now, whereas previously you had to camouflage a participatory action research project and call it something else. So NH and MRC didn't think it wasn't somehow not rigorous enough.
Yeah. So I think the action part of it is very much, in order to make change, we all, as partners, need to take action. But the sort of action we can take depends on the role and where we sit within the system. And by all working together for the same objective, but within our own roles and spheres of influence and the way we can influence the system, having a shared sense of purpose, we can change the system more effectively. And really that goes to the question, what are the things that have enabled that? And one clearly is infrastructure, in research infrastructure in rural communities, because to work in partnership and within communities, you have to be part of the community. So funding for facilities, but also salaries for people to live and work in rural environments. And the second is funding for research projects that prioritises research issues, but also prioritises the way that research is done along the way that I've described and I think Dennis is describing. And we're seeing some good examples of those coming through.
Okay, I'm going to try and summarise what I think is a fabulous conversation, because I absolutely agree with everything that everybody said. But let's start with spirit and integrity. For those of us who live and work in rural, remote regions, you don't survive without spirit and integrity. Authenticity is the key element. So for those of us who work there, we have to be seen as someone who operates within that ethical environment. I think it totally works. I think the point that David's made about the setting up of the infrastructure, which was done predominantly for training purposes and workforce purposes, has actually located university staff in those communities. And that makes a huge difference. We're not urban-based researchers trying to do something for a community that you don't belong to. I think the other thing that has happened with the relocation of clinical schools and university departments of rural health is the training of local researchers. When I left UDRH, we had something like 10 or 12 PhD students. They were students who lived or worked rurally or remotely. Now, 10, 15 years ago, that was absolutely unheard of. We're actually training the generation of clinicians and policymakers who are there, who are part of the system. So we're building capacity and we're building infrastructure locally. The other thing that I really wanted, and that's one of the reasons that I actually moved from a city-based position. I had done a lot of work internationally, and my work internationally was all about rural or remote community or small villages. And I'd never had an opportunity to work with Aboriginal Australians. I had an opportunity in Darwin to start to work with Aboriginal Australians. But my goal was actually to make researchers part of the system. I didn't like this notion that we were seen as somehow esoteric people sitting in tall towers of a university. And the biggest satisfaction from my professional life, I think, is that when I left Lismore, research is totally embedded in that local health district. You couldn't possibly imagine that we didn't fit. Not only do we fit, we belong. Now, that for us as researchers, given this spirit of authenticity and really wanting to contribute, is absolutely crucial to make sure that we're effective. But it wasn't something that existed 15 years ago or 10 years ago. People didn't imagine that a researcher wanted to come and live there and work there and be part of the system. Now they take it for granted that researchers want to live there, want to be part of the system and want to contribute. Now, I have actually finished with 3 minutes to go. Let's come back to anyone. Have we missed anything crucial out that we need to say? Lucie, please.
I was thinking also that... Yeah, no, it's on. I was thinking that one of the things that we pride ourselves about in rural clinical work is being part of a multidisciplinary team. Mm-hmm. And I get a bit disorientated when we think about and talk about multidisciplinary teams sometimes with my urban colleagues, because within the research context, my multidisciplinary teams include, or they're not my teams, but the teams I'm involved with include demographers and council members and medical students and, you know, just a huge range of people well outside the health sector. And I think that the richness of wisdom that can evolve from those kind of teams is recognised more and more in the research milieu. And that is really important. It gives us a heads up in rural areas.
I think that's useful. Ross, have you got anything you'd like to add?
I think I've said enough, thanks.
David? Dennis?
Just one thing, I think. Lucie's alluded to the fact that, you know, rural people speak out about things.
Yeah.
I think there's a useful way of kind of garnering that energy and that enthusiasm, which is that we've talked about generating the evidence, and that's a crucial part of what we do. But we have to make that evidence sing, because we can't assume that the evidence will actually drive policy and drive change. If that were the case, we'd be living in an Australia where climate change was taken seriously. And we're patently not. You know? So something's happened between the evidence being generated and the evidence actually affecting change.
Okay, can I say this is a chorus that you all have to join? David, Andrew and I have just published something in the latest Rural Health Journal on NH and MRC funding for rural and remote research. It's at 1 to 2% of the total research quantum. It should be much higher than that. So you've now got the published peer review evidence. I've talked with the CEO of NH and MRC. Paul has listened to us this morning. He's got a copy of the paper. Mark has already been approached by the head of NH and MRC to talk about this, but please sing it loudly as a chorus, because I think we've now got the evidence from this piece of research that will enable us to get improved funding for rural and remote health research. And we've now got, as David says, capacity to deal with it.
Excellent. Thank you very much.